Presentation is in regards to stroke. So, learning objectives, we're going to define stroke, provide health statistics on the disease, explain the pathophysiology, etiology, pathogenesis, and the clinical course, describe how it affects movement control, outline treatments and medications, and also discuss the benefits of exercise and exercise prescription guidelines associated. So some statistics evident just here. So in 2005, stroke was known to be one of the leading causes of death and adult disability in both Australia and America. It also needs to be noted, which is not on the slide, that stroke is the third most common cause of death and leading cause of long-term disability. It must also be known it places a great demands on family members and caregivers, and stroke also has an enormous financial burden, not only on the families but for society as a whole. So, stroke is a sudden loss of neurological function resulting in the focal disturbance of cerebral blood flow due to ischemia or a hemorrhage. So it's commonly referred to as brain attack, which generally involves a loss of blood flow to a region within the brain. When a stroke takes place, neurons within the brain die, which can then lead to brain damage, consequently causing disabilities. Two forms of stroke, ischemic. So ischemic stroke is the known build-up of atherosclerotic plaque in the arteries, which ultimately leads to a blood clot and is responsible for 88% of total strokes. Hemorrhage stroke is known as an excessive bleed in the cerebral artery and is responsible for the following 12%. It's also the most severe. So we have some risk factors. Some modifiable risk factors include hypertension, alcohol intake, obesity, cigarette smoking, and illicit drugs also, in particular cocaine. Hypertension is the most common cause for hemorrhage stroke and accounts for up to 60% of all these cases. There are also some non-modifiable risk factors. Includes genetics, the aging process, ethnicity, and any history of a stroke. So the pathogenesis are the three main phases for an ischemic stroke. Thrombosis refers to atherosclerosis is the most common pathological feature of vascular obstruction resulting in a stroke. So the plaque undergoes pathological changes such as ulcerations, calcification, intraplaque hemorrhage. So the susceptibility of the plaque to disrupt, fracture, or even ulcerate depends on the structure of the plaque and its composition or consistency. The embolic stroke can result from embolization of an artery in the central circulation from a variety of sources. So besides clot, fibrin, and pieces of atheromodule plaque, materials known to embolize into the central circulation include fat, air, tumour, bacterial clumps, or foreign bodies. So global ischemia is a reduction in systemic blood pressure, which is often a major reason for ischemic stroke. Neurons within pyramidal cell layer of the hippocampus and the Purkinje cell layer of the cerebral cortex are more vulnerable to ischemia, mainly due to the amount of glutamate available within these neurons. So the hemorrhage stroke also has three main phases. We've got the initial phase, which is initial hemorrhage is caused by a rupture of cerebral arteries, and it's influenced by some of the above risk factors mentioned. Hematoma expansion is the next one. It occurs hours after initial symptoms onset and involves an increase in intracranial pressure that disrupts the integrity of the local tissue and blood-brain barrier. In over a third of these patients, this hematoma is associated with hypoglycemia and hypertension. Following the expansion, cerebral edema forms around the hematoma, secondary to inflammation and disruption of the blood-brain barrier. So this pre-hematoma edema is the primary etiology for neurological deterioration and develops over the following days post-stroke. So we got atherosclerosis is known to be the primary cause of ischemic stroke. It's the build-up of plaque in the arterial walls. So further, it is recognised as an active process that involves molecular signals to produce changes in cellular behaviours, endothelial dysfunction, and inflammatory responses. Generally, there is an accumulation of lipids, inflammatory cells, connective tissues within the arterial walls, whereby the plaque is then developed at irregular levels. So the genesis of the atherosclerosis is known to be slow, progressive, and involves some cardiovascular cardiovascular risk factors, including diabetes, inactivity, obesity, and smoking. So signs of a hemorrhage stroke may involve decreased level of consciousness, migraines, sporadic blood pressure increases. So furthermore, hemorrhage strokes can occur due to minimal warning signs, a lack of control that the brain has with a potential bleed within the brain. So the cause of cerebral hemorrhage stroke seems to be predominantly associated around hypertension. However, other frequent causes involve vascular malformations, intracranial bleeding disorders, and so many of the signs and symptoms relating to stroke depend upon the location and size of the actual lesion. However, memory loss in it. Ehrman et al. He states that memory loss and paralysis are two of the most common symptoms experienced with the onset of stroke. So, in the case of the paralysis, brain damage is known to affect the opposite side of the brain. So, if the left side of the brain is affected, then most commonly the right side will be paralysed. Also, if the brain is affected on the right side, then the body is more common to see patients suffer from vision problems and show awkward or inappropriate behaviour. Whereas on the left side, you're more prone to see some speech problems and slow, cautious behaviour. So we get the effects on motor control. The damage of a stroke can cause both physical and cognitive impairments. Motor control impairments from stroke are generally associated with what is known as hemiplegia or hemiparesis. The most common motor control impairment from stroke is known as the hemiparetic gait, which is associated with symptoms of spasticity, lack of sensory information. Both afferent and efferent pathways are affected, postural stability and strength. So furthermore, the ability to walk post-stroke has been shown to affect more than 80% of the patients. However, it is possible to gain the ability to walk again through the use of a rehabilitation program. So stroke can also influence afferent neural pathways that are responsible for maintaining the posture. Postural control is critical for stabilizing our head, neck, thorax, and thus prevents us from slipping or falling. When descending neural pathways become damaged, the spinal neurons produce abnormal regulation. So this abnormal activity of the spinal neurons adversely changes the structure of a postural and stretch reflexes, which can then in turn influence voluntary movement patterns. So additionally, when neural pathways become affected, it may cause deficits in one's ability to maintain motor control due to the increase in muscle weakness, abnormal synergistic organisation of movement patterns, impaired regulation of force, decreased reaction times, or abnormal muscle tone. So motor control is generally considered to be one of the most complex motor tasks post-stroke. However, patients may still have the ability to retain these neural competencies, and this is due to mechanical linkage for the stimulation to the motor unit of the weakened site. Reacquisition can be attained through specific neural rehabilitation pathways concerning visual and proprioception feedback systems. So the reacquisition task may be due to functional neural network activity known as the central pattern generators within the spinal cord. Through this, appropriate rehabilitation and exercise programs post-stroke, the hemiplegia and hemiparesis may be enhanced and motor skills can be relearned through these neural proficient pathways. So we've got treatments and interventions. We've got surgery. So the most common surgery that's used is called the carotid endarterectomy. It's able to remove plaque that's built up within the carotid arteries. However, there is increased risk of death or even stroke during surgery. It's been stated in a study conducted by Halliday that even with surgery, not all the risk is eliminated. Research conducted by Barnett has also stated that patients that do have this surgery showed signs of improvement for the following 2 to 3 years. Pharmacological treatment undertaken by the patient commonly depends on the type of stroke. So, antihypertensive medications such as labetalol are extremely important in most, and it's probably one of the most common forms of drug used to treat a hemorrhage stroke. So, labetalol is an effective drug that has no negative adverse events. With acute strokes comes an increase in blood pressure. So, this labetalol works against this and decreases blood pressure, which has been suggested to reduce mortality or potential disability, cited by Potter et al. So antiplatelet medication such as aspirin has also been used within the treatment of stroke. So aspirin is usually used within 48 hours of an ischemic stroke and reduces 14-day morbidity or mortality. However, the benefit is not really known to be that great. So rehabilitation for stroke patients is also an intervention. So it's not limited to physical therapy, but it mainly revolves around this. And the intervention is primarily used to restore balance, movement, and coordination. Also, speech pathology is also a common treatment undertaken during rehab because some people suffer from speech problems prior to post-stroke. So we've got benefits of exercise. We've got the strength. Goal of our first stroke, the goal of stroke rehabilitation is to increase functional capacity as the aerobic fitness level of many stroke survivors does not even reach a critical value that is essential for active daily living tasks. Strength training has the ability to reduce muscle atrophy, and which may influence hypertonia, which is evident within the stroke. Also, it's been known that resistance training can help. However, more common tasks, so functional resistance training, seem to be more beneficial. So the three main goals of rehab include preventing prolonged inactivity, decreasing the risk of another attack, and increasing aerobic fitness. So within the first goal, patient needs to begin physical conditioning program designed to regain their pre-stroke levels as quickly as possible. So if we've got somebody that's in hospital, simple exposure to orthostatic or gravitational stress during their stay in hospital has been shown to prevent the likelihood of any deterioration in exercise tolerance that may follow this stroke. To prevent the likelihood of another attack, the main goal they must work towards is to decrease any risk factors that have been linked to stroke. So an aerobic program is able to enhance glucose regulation and decrease body weight, blood pressure. It also decreases LDL cholesterol, triglycerides, and total cholesterol. And they've all been linked with the onset of stroke. So in regards to cholesterol as well, research has also stated that exercise increases our HDL cholesterol, which is our good cholesterol, and also improves coronary artery endothelial function, cited by Gordon et al. These findings are consistent with the growing evidence that intervention promoting plaque stability, favourable changes in vascular wall function, or both are important in the management of patients suffering a stroke. So the third major goal of rehab is to improve their aerobic fitness. That may have been affected during their recovery period. Evidence suggests that stroke can be reduced with regular physical activity in individuals of all ages, sex, or ethnicities. So researchers also suggested that aerobic exercise increases a stroke patients' endurance, which in turn can improve their ability to complete some simple daily living tasks such as going to the shops and buying their groceries. Resistance training also helps with postural adjustments, and that have been known to be lost due to the neurological impairments. So we've got some exercise guidelines. Prior to commencing an exercise program, it must be stressed that individuals need to undergo scanning to identify any other problems that may be of concern, i.e. the cardiovascular risk. Most common form of exercise would be aerobic exercise. Its duration and frequency and intensity is usually around 40 to 50% of our heart rate reserve for as long as 20 to 30 minutes, 3 to 5 sessions per week. We want to increase our heart rate reserve to around 60 to 80% throughout our program. Also want to increase our minutes exercising. So finally, I just want to say this presentation will conclude that exercise prescription and rehabilitation can assist in the relearning of movement patterns, specifically relating to hemiplegia or hemiparesis post-stroke. Functional capacity plays an important role in regaining cardiorespiratory fitness and strength, and can be dramatically improved through the implementation of exercise training. Each stroke patient will require a modified and exercise training program, intensities and duration depending on their current fitness levels and severity of their health. So, however, according to these findings throughout this paper, aerobic training sessions should be 3 to 4 days, and with some strength components suited for those who suffer from neurological deficits such as hemiparesis. Overall, exercise is a great benefit to stroke patients in the management and prevention of cardiovascular disease.